Morning everybody. Today's topic is endocrine disorders. In this topic, mainly we are concentrating about the surgical treatment for the medically compromised patients regarding about the endocrine disorders, especially diabetes and other endocrine disorder problems. So, how you will go for a medically compromised patient like diabetes patients? What are the medications we can prescribe for that patients? What are the treatment procedures we can do? Like that in this topic, we are going to do. Endocrine disorder or endocrine system is the widespread consists of the glands that exert their effects of means like chemical hormones secreted into the blood circulation. So they secrete their products directly into the blood rather than through a duct like a pituitary gland, pancreas, thyroid, adrenal glands like that. So endocrinopathies may be caused by the excessive hormone or diminished hormone release or hormonal resistance. These are the mainly affecting problems in the endocrine. So the main function of the endocrine is to assess by machine by through the blood plasma, hormones are metabolite in the urine, dynamics test for the hormone secretion or regulation, or level of the hormone receptors. So mainly we are checking through the blood plasma or through the urine. So in endocrine system continues within number of glands like pituitary, thyroid, parathyroid, adrenal, pancreas, and thymus. So first one is the hypothalamus and the pituitary gland. Hypothalamus is a part of the brain that controls many other endocrine glands via pituitary function by hypophysiotropic hormones termed as releasing factors. So the pituitary gland consists of uh, anterior lobe, intermediate lobe, posterior lobe. Anterior lobe is consists of the mainly by the growth hormone, thyroid stimulating hormone, then adrenocorticohormone, then corticotropin, somatostatin. These are the mainly by the anterior lobe. Intermediate by the A and B melanocyte stimulating hormone, posterior lobe by the vasopressin and oxytocin. So the hormones by the anterior lobe, intermediate and the posterior lobe. Posterior by the neurogenesis, I already mentioned, antidiuretic hormone and the oxytocin, ADH and the oxytocin. Hypothalamus is control the higher centers in the brain, and feedback control the influence of the amount of hypothalamic hypophysiotic hormone secreted. Pituitary function is sometimes caused by the pituitary tumors, usually by microadenomas. So the usual cause of the hypopituitarism are the local hypothalamic or pituitary lesions such as tumors, radiation infractions, and pituitary following the postpartum hemorrhage. Posterior pituitary is called diabetes insipidus. There are two types: diabetes insipidus and diabetes mellitus. Posterior pituitary hyperfunction called diabetes insipidus. The results of hypopituitarism are associated with the target glands called gonads, thyroids, adrenal cortex, and hyperfunction, hypoadrenalism, and hypothyroidism. Adrenal pituitary hyperfunction. Adrenal pituitary hyperfunction means the growth hormone excess like gigantism, acromegaly. Like in the dental managing, the acromegaly and gigantism are mostly we are seeing in this patient. You can see the blindness, diabetes mellitus, hypertension, cardiomyopathy, arrhythmias, and hypopituitarism. Kyphosis or spinal, it's a bending of the spinal cord. So the other deformities we can see in these kyphosis. So what will happen mainly, it will affect the respiration and there will be difficulty for general anesthesia. The clotting opening and narrowed by the cords and mobility will be reduced. So it is very difficult for the general anesthesia and goiter may be further emphasize the airway obstruction. Rarely the acromegalis develop a Cushing syndrome or hypoparathyroidism due to associate with multiple endocrine adenomas syndrome. And mainly we can see the mandible enlargement like class 3 malocclusion and spacing of the teeth. Next one is endocrine diabetes. Diabetes, I already mentioned there are two types, diabetes mellitus and diabetes insipidus. Glucose consumption depends upon the pancreatic hormones like insulin from the beta cells of the islets of the Langerhans and the glucagon from the alpha cells in the islets. There are two types, beta cells and the alpha cells. Insulin facilitates glucose transport into the cells and thus lowers the blood sugar level. Glucagon stimulates the liver to convert the glucose into the glucose, thus raising the glucose level and having the opposite effect of the insulin. So the other hormones that influence the glucose increase mainly the catecholamines, corticosteroids, thyroid hormone, and growth hormone. Diabetes mellitus is a disorder caused by an absolute or relative lack of insulin. There can be a low output of the insulin from the pancreas or peripheral tissue may resist insulin. So the main clinical features we can see is polydyspnea, polyuria, polydysphagia, difficulty in the breath, visual activity, and arthrosclerosis, diabetic neuropathy, weight loss, ketosis, ketonuria, hyperventilation, like that. These are the main clinical features noticed in the diabetes mellitus. And we can see recurrent blood vessel, retinopathy, cataracts, fever commonly seen. Renal damage and failure will be there, and vulvonovaginitis, pruritus, and candidiasis will be there. Paresthesia, peripheral neuropathy, loss of sensation, and there will be higher susceptibility to the infection also. So mainly the clinical features are the polydyspnea, polyuria, polydysphagia, difficulty in the breathing, visual acuity disorders, diabetic neuropathy, atherosclerosis, and there will be infection will be in the vaginal infection, skin infection, UT infections, paresthesia in the lower extremities like the toe and the finger, and weight loss, fatigue, nausea, vomiting, and a rise in the temperature, and there will be high susceptibility to the infection also. These are the main clinical features. And next one is the primary and the secondary will be there. There are primary are divided into type 1 and type 2. Insulin dependent and non-insulin diabetes mellitus. Insulin dependent, that is seen on the juvenile, non-insulin seen in the mature onset. And the other type secondary like drugs like corticosteroid, thiazide, diuretics, beta blockers, endocrine disorders like acromegaly and Cushing syndrome, pancreatic disease, pancreatitis, pregnancy, that is mostly seen, usually represented type 2 diabetes exposed in that be increased insulin resistance or pregnancy. So the type 1 and type 2 we can see, type 1 seen on 15-year-old, type 2 seen in the more than 40-year-old, and the body will be thin in type 1 and type 2 they will be little obese. The severity will be more severe in the type 1, type 2 will be more. And main is ketoacidosis will be common and type 2 is uncommon, and the use of insulin is almost fully will give, and type 2 will be 20 to 30 percentage. So the normal glucose level we can go for the diabetes mellitus. So this thing is fasting blood sugar is 4.4 to 6.1, random blood sugar will be 4.4 to 8, the postprandial will be 6.7. HbA1c glucose hemoglobin, that will be 4.8. So the mainly we are noticing for the HbA1c is that is for the 3 months average of the blood glucose level in the hemoglobin. So the most advantage for the reason we can go for HbA1c, so we get the correct value of 3 months of glucose in the blood. So the normal value is like below 5% is normal. Pre-diabetes is between 5% to 6.4, and diabetes will be 6.5 above. So this is the main thing. Suppose some patients will notice glucose will be normal showing, but after that it will become more after accession or something like become more infection. So when you go for HbA1c, we can see the 3 months of blood glucose level in the hemoglobin. So we can understand regarding about the blood glucose. The causes of type 1 diabetes is insulin deficiency and autoimmune factors selectively destroy the insulin producing the beta cells. But in the type 2 diabetes, insulin resistance and the resistance to the action of the insulin in the peripheral tissue, defective insulin secretion in response to glucose stimulation, and increased glucose production in the liver. So the main complications we can see acute complications like hypoglycemia, coma, diabetic ketoacidosis. Chronic, if become the there will be diabetes will be, yeah, uncontrolled diabetes, like, and then we'll go for a retinopathy, neuropathy, nephropathy. Retinal or the I am cataract problem, or neuropathy, there will be nerve damage and kidney failure will be there. And macrovascular disorder like ischemic heart disease, peripheral vascular disease, and hypertension, and renal damage and failure. And there will be increased susceptibility to the infection. These are the main things we can notice in the diabetes. So the main reasons we are telling is in the impaired leukocyte hematosis, advance of phagocytosis, and increased cutaneous T cell function, and diabetic neuropathy and peripheral vascular insufficiency favors the insulation and development of skin infections. Capillaries supplying blood to the skin and soft tissue are narrowed and blocked. So what will happen? It is when the atherosclerotic plaque built up in the bloodstream. So there will be ischemic heart disease and hinder the delivery to the oxygen and nutrients to the peripheral tissue. So that will lead to infection and non-healing wound. These are the main things we can see. Hypoglycemia, that is blood glucose is below 50 milligram per deciliter in the adult and 40 milligram in the children. So neurologic dysfunction, diminished cerebral functions, changes in mood, sweating, tachycardia, increased anxiety, unconsciousness, and seizure. These are the, in blood glucose, the hypoglycemia is the most dangerous one compared to the hyperglycemia. Yeah. So in hypoglycemia patient, there are two types: conscious and unconscious patients. So in conscious manner, first you recognize the problem and after they check if the blood glucose is below the 5, like then it's hypoglycemia, and if the patient is conscious, discontinue all the dental procedures and position the patient airway, may breathing circulation check, and administer oral hydrocarbon. If the patient can drink, it is good. If unsuccessful, administer parenteral carbon, then means we inject IV line dextrose. All this we can inject. If unconscious, recognize the problem first and check the blood glucose level, discontinue the dental procedure, position supine and elevate and airway breathing circulation check. And the patient is unconscious, that's why we're giving IV 50% dextrose or IV or IM 1 milligram glucagon, transmucosal sugar or rectal honey or syrup we can administer. Monitor the vital signs in every 5 minutes and administer oxygen because patient is unconscious. That's the main thing. So before, if the patient is a diabetic, check the blood glucose level, and if it is in normal value, okay, we can continue. If it's in below around 5 like that, no, we give oral carbohydrates. If it's a conscious patient, we can give oral carbohydrates, otherwise don't give. Hyperglycemia, it's blood glucose more than 250 milligram per deciliter, and the main thing is dry warm skin, Kussmaul's respiration, that means deeper breathing will be there, fruity sweet breath odor will be there, altered the level of the consciousness. And the management of hyperglycemia is simple compared to the hypoglycemia. Treat unknown diabetic emergency hyperglycemia until the condition is known. Hypoglycemia causes more rapid and fatal damage. Administer IV insulin if available. IV infusion means 5 testosterone and water over normal size may be started before the emergency person arrives. The drugs used in the diabetes mainly is sulfonylureas, biguanides, thiazolidinedins, maclidinate analogs, alpha glucanase inhibitors. These are the drugs mainly used for the diabetes. Mainly we can see if the patient is diabetic now, mainly metformin, these are the drugs, glipizide, these are the commonly drugs patient will take. But the drug interactions will be there. If the patient is taking sulfonylurea, cortisol, displacement of the inhibition of metabolism of sulfonylurea leading to hyperglycemia, and if you giving the erythromycin inhibition of metals leading to toxicity. If the patient is taking aspirin and the other NSAID displacement and reduction elimination which leads to toxin and risk of bleeding will be there. So if the patient is taking sulfonylureas, then these are the drugs interactions. So be careful when you give administering the NSAIDs and the erythromycin like drugs. The signs of diabetes mainly severely peritonitis and oral candidiasis will be there due to multiplication of candida albicans due to impaired glucose level and the immune mechanism, and angular stomatitis, dental abscess and facial space involvement will be there. Sometimes will be localized osage, means dry socket can develop and show the delayed healing, burning mouth, increase the caries activity, atrophy and lingual papillae fishing and dry tongue, delayed wound healing, increased polymorphic hematosis, cirrhosis, swelling on the salivary gland, neuropathy, paresthesia will be there, temporary lingual label paresthesia that are already mentioned, neuropathy will be there. So, how will you manage these things? It is to avoid hyperglycemia. That is most important thing. Keep hyperglycemia below harmful level. So that means you must to maintain the glucose level in the normal value. That is more good. Should not cause a delayed wound healing and phagocytic dysfunction. And oral glucose level. If the level is too low, less than 500, then better you give oral glucose. Well controlled and insulin dependent diabetic patient. Accessions like a minor surgical procedure under LA can be carried out within 2 hours of breakfast, and a morning insulin injection will be given. No change in the insulin regimen. Suppose if the patient came for accession and patient is diabetic, some patients what they were to do, they will skip the breakfast. If the patient skips the breakfast, ask the patient to take the breakfast, then only they can start the procedure. And also, as a patient, don't stop any insulin drugs after the accession. or before also. Ask the patient to continue their insulin drugs and not insulin drug, insulin and the drugs taking. Continue the drugs and continue what are the drugs what we are prescribing. So there is no change in the drug. So after going for accession, check the blood glucose. If it is normally, we can continue the procedure. If it's a little below, no, then give oral hypoglycemia, oral glucose we can prescribe. Then only we can start the procedure. And mental control and insulin dependent evaluation of multiple accession is suppose there will be already mentioned that oral session there will be multiple caries, oral candidates like that, no? So there will be chances of multiple accession will be there. In that environment, first prior assessment of the blood glucose means fasting, midday or evening. Patient is put on soluble insulin and stabilized. Early morning procedure is administered because most of the patient, if you go for on the noon time like that, there will be chance of hypoglycemia. So avoid that thing. Ask the patient to come on morning, then only we can do the procedure. After the procedure, blood glucose estimation done. IV infusion constant glucose generally 10 gram, soluble insulin 2 units. Then GAK infusion also is set up till the oral feeding is resumed. Priority insulin regimen can be started after the patient starts feeding. No. GAK infusion, that means no glucose, insulin, and the potassium. So 1000 ml of glucose plus 250 milligram of potassium plus 15 units of insulin is called a GAK infusion. That will be prescribed. That's the main thing. GAK infusion, glucose, insulin, and the potassium. Next one is the management. Steroids increase the blood glucose. The constant use of steroids that can increase the glucose level, and the doxycycline, tetracycline support enhance the insulin and hypoglycemia. NSAID, there will be higher risk of renal damage and the gastrointestinal bleeding. I already mentioned regarding that erythromycin and the NSAID are drug interaction with the, so avoid the higher use of non-steroidal anti-inflammatory drugs. And antibiotics 3 to 7 days moderately and poorly controlled diabetes. That means if the patient is using patient is using, patient have poorly control the diabetes like that, no? So better ask the patient to take the insulin, and also the meantime after accession we must give antibiotic. Then only we can control the infection. Otherwise there will be higher chance of infection will be there.